all the options B, C, D can be used, but topical steroids do not have any role. So option A is the one which is not used in the acne. So briefly about the acne and its treatment. So there are 4 grades. I think I am coming in the way, so I will just vanish for some time. Okay, so grade 1, oh, 1 second, grade 1, grade 2, grade 3 and grade 4. So what are these grades based upon is, if the predominant lesions are comedones, then we are going to call it as grade 1 acne. If they are papules predominantly, then it is grade 2. If there are pustular lesions predominantly, grade 3. And if there are nodulocystic lesions, that is nodules and cysts, both of them are there, then it is grade 4. And please remember, grade 4 acne is the most severe form of acne vulgaris, most severe form of acne vulgaris. And if you look at the treatment part, grade 1, 2 and 3, in all of them, one thing is commonly used: topical retinoids, topical retinoids, topical retinoids. And these topical retinoids, there are many topical retinoids which are FDA approved for acne vulgaris. Tretinoin can be used, adapalene can be used, tazarotene can be used. So very, very important. All these topical preparations can be used in the case of grade 1, 2, 3 acne. And in the case of grade 2 acne, where papular lesions are predominantly there, along with topical retinoids, we should add topical antibiotics. We should add topical antibiotics, and there are so many antibiotics: nadifloxacin, clindamycin. These can be used. And apart from that, even benzoyl peroxide also falls under this category, that is topical antibiotics. So it is an exception, we can say. It is used in all those conditions wherever the patient has a resistance to topical antibiotics. Okay, so even benzoyl peroxide can also be used in the acne. That is one thing which you must remember. And in the grade 3, as you can see, pustular lesions are there. So it is much more complex, and the treatment needs to be more aggressive. So we are going to add oral antibiotics. And in this, tetracycline group of drugs are very, very important for you to remember: minocycline and doxycycline. And also we can use azithromycin and erythromycin also. Whereas in grade 4 acne, the only important medication which you must remember is isotretinoin. Isotretinoin. And one more thing, isotretinoin is an oral medication. Isotretinoin is not available as a topical medication. Very, very important for you to remember. And coming to the steroids, so you must know that in some types of acne, steroids can be used. And even oral steroids can be used. And what are those types of acne? You must remember, it is acne conglobata. And one more condition is acne fulminans, which is also called as acne maligna. So in these two conditions, patients are going to have excessive inflammatory skin reaction. So to reduce that inflammation, acute inflammation, we should give some form of strong anti-inflammatory agent, and steroids are the one which are going to be used. So now please try to answer this question: asymptomatic lesion of dorsum of the arm, so forearm and shaft of the penis. So what is the diagnosis? Yes, Dr. Mahabubasha, Akash, both of you are telling lichen nitidus. So I hope you have answered this question also, lichen nitidus, which this is also, we can say, it was discussed so many times. So the manifestations of lichen planus and scabies are very much different from this condition. So here the answer is lichen nitidus. So let us see what you are able to see in the image. Tiny pinpoint papules you are able to see, and these papules are also slightly hypopigmented. So these are the characteristics of the lesions which you are able to see. And I think in the question, it was it mentioned that this was a child. So child was this mentioned in the question. So the students who told me, they have not confirmed that whether child was given or adult was given. So can you tell me whether in this question child was what was mentioned or not? So Dr. Akash says it was a guess in the exam. So very good. Sometimes a guess it can become correct. Yes, can you tell me whether this word child was it mentioned in the question or not? Yes, friends, come on, just tell me whether this word was given or not. Okay, child. Okay, fine. So actually, this was the child was there, sir. Thank you so much, Mehboob Basha. So this was a question which I discussed previously. Young boy presented OPD with multiple shiny pinhead-sized white papules over dorsum of the head, forearm, and penis. What could be the diagnosis? So you can see the options are also copied, and in the exam they were given. So most likely, maybe this was. Uh, a previous MCQ which was asked in other exam, most likely. Okay, so answer here is lichen nitidus. So lichen nitidus, we can see skin color to shiny papules, and this is most likely seen in children. Okay, in the question, children will be mentioned as a very important clue, and you can see here there are so many shiny papules which are very closely arranged. Usually there will be this characteristic grouping of these lesions, and the sites as mentioned in the question, they can be there present over the forearm, forehead, and most importantly the question also mentioned shaft of the penis having these kind of lesions. So this could be one very important clue, and there is one very important phenomenon which we can see here. It is Koebner's isomorphic phenomenon. Koebner's isomorphic phenomenon can be seen here, and in the histopathology also there is one very important finding which you must remember. It is called as so you can see these are the rete ridges. So in between these rete ridges you are able to see a collection of the lymphocytes. So you are able to see a collection of the lymphocytes can be there, and this is appearing like a ball. The collection of lymphocytes is appearing like a ball, and these rete ridges are appearing like a claw. So this claw, which is actually rete, and this ball which is actually a lymphocytic collection. So both of them put together, it is given a descriptive term called as claw clutching ball appearance. So you can see this is the rete ridge, and this is the collection of the lymphocytes, with the help of which you can remember easily. Claw clutching ball appearance is seen associated with lichen nitidus. And one more thing which you must remember is lichen nitidus has nothing to do with lichen planus. Okay, lichen planus is a completely different condition in which we are going to see there will be a collection of peas in the lichen planus. So you can see the plexors are the sites which are affected. So plexors will have the lesions, and the lesions, the color will be purple, and they are going to be extremely itchy, that is pruritic. The lesions have a plain top, that is the reason why this condition is called as lichen planus, and the lesions are having a polygonal shape. They are papules and plaques. So these are the morphologies, papules and plaques. And in the nail, very important finding, nail pterygium will be there, and also nail in the nail puptent sign is also one more feature which you must remember. And ultimately, when the lesions of the lichen planus will heal, they are going to leave behind a very bad hyperpigmentation. So these are all the points regarding lichen planus which you must remember. This is basically a papilloscomus disorder, which is basically a chronic inflammatory skin condition. And scabies, this is very simple. I don't want to waste the time. So scabies, the buzzwords will be family history will be there, nocturnal itching will be there, that nothing has been mentioned in the question, excoriated papules, burrows will be there, serpiginous tunnel will be there, and most importantly web spaces will be involved. Burrows are the hallmark or pathognomonic lesions in scabies. And now please try to answer this question. I hope this was the exact question which was asked. If there are any changes in the question, please do put whatever changes you feel were there in the chat section. And mind you, this was a repeated question, and yes, everybody please give me a thumbs up. Everybody please give a like to this video. Everybody please give a like to this video if this was the question which was actually asked in the exam. Yes, everybody please give a thumbs up if this was the question and these were the options which were given in this question. Yes. So what do you think is the answer? Please post your answer in the chat section, friends. Everybody, what do you think is the answer? Come on, come on. So I'm waiting for the answer. Still nobody has given me answer. A 68-year-old. I hope all of you have answered this right. This is a repeat question, very, very important. A 68-year-old male, that is an elderly male, came with tense bullae on urticarial base. After some time, the roof or bulla got laid down or settled. So what is the diagnosis? Very, 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 very important repeat question. This was in fact repeated, and there are n number of clues from which you can synthesize the answer. Yes, Dr. Mehboob Basha says tense bulla, so I will mark bullous pemphigoid. Dr. Akash says option D is the answer. Okay, okay. So I can see there is a disagreement between the students. Yes, come on, friends. All the other students, please do post whatever you feel is the answer, please. Okay, so this is I will tell you very, very, very important. I can tell you in FMG also this vesicular bullous disorder topic will come, and not only that, even in NEET also this topic will come. Very, very, very important. And this was in fact discussed in my YouTube channel in the 2 to 3 days back videos also. So please remember, whenever you see this word tense bulla on urticarial base, so the only and only diagnosis which you must think about is bullous pemphigoid. Okay, so I will tell you briefly. That is the reason why here the bullae which will be formed will be very, very tense bullae. Very, very tense bullae. So if in the question flaccid bullae is mentioned, then you must think about some pemphigus group of disorder. Whereas if it is mentioned that it is tense bullae, then you should think of either bullous pemphigoid. Okay, bullous pemphigoid. Okay. And in the question, if you see tense bullae is mentioned, so with that you can rule out pemphigus vulgaris as well as IgF pemphigus. Why? Because IgF pemphigus is basically a type of pemphigus vulgaris. So basically a type of pemphigus vulgaris. And if you look at dermatitis herpetiformis, so this is subepidermal blistering disorder, but the manifestation of dermatitis herpetiformis clinically will be different. So let us see what will be the clinical manifestations of bullous pemphigoid and dermatitis herpetiformis briefly. So in bullous pemphigoid, the age group is 60 to 80 years, that is elderly. Elderly patients will present with itching, so they will have initially itching, and these itching will be followed by formation of urticarial plaques, that is wheals will be produced. So you are able to see these are the wheals, and these wheals will be topped by bullae. And what will be the characteristics of those bullae? Very, very tense. So if you observe this bulla, you can remember your holy days where the balloons will be filled up with the holy color and they will be thrown at us. Okay, so that is the consistency of the bulla. Very, very tense. It is completely filled by the fluid. So this is going to be the description in the case of bullous pemphigoid. Okay, and these are the actual lesions which you are able to see. And one more peculiar feature about the bullous pemphigoid is that once these rupture, bulla, they don't extend onto the normal skin. They will just settle down. The bulla will just settle down, and it will heal on its own. So that will be the progression of these lesions. The bullous pemphigoid lesions are not going to extend onto the normal skin, so they will form erosions and they will very easily heal, and there will not be any tendency to extend onto the surrounding normal looking skin. Very, very important. And in the case of dermatitis herpetiformis, which is also called as Duhring-Brock's disease, this has an important association which you must remember. It is celiac disease, or it is also called as gluten-sensitive enteropathy. It is also called as gluten-sensitive enteropathy. And the manifestations here are going to be patients will present with papules, vesicles, mainly over the extensors. So this is the characteristic of dermatitis herpetiformis. Okay. Yes, question was severe itching age 60 years. Yeah. So if you remember, if you look at the bullous pemphigoid, I told you that urticarial plaques will be there in the patients, and that is the reason why patients will have severe itching in the case of bullous pemphigoid. Very important for you to remember. Sir, for acne question, 17-year-old was given, so can we use isotretinoin for less than 18? So isotretinoin, was it given in the question? So students told me that topical retinoids, topical tazarotene, and topical what was that, benzoyl peroxide and fluocinolone. These were the options, but no one told that isotretinoin was given or not. So all of the students who are watching, please tell me whether isotretinoin was mentioned in the question or not. And please try to mark this question. This is also a very important repeat question, we can say. So all those students who are watching, if you find this session helpful, please while watching this session itself, do give this video a thumbs up, so that I will understand that these kind of videos are helpful, really helpful, and I also wish to continue these kind of sessions, and I'm actually planning to make just 15-20 minutes of daily live quiz in the YouTube channel. So if you wish that these kind of sessions should happen, please do give this video a like. Dr. Akash, option A is what Dr. Akash want to say, and very good, thank you so much. So history of vegetative matter trauma was not there, prick word was there. So okay, so there was a prick with the vegetative matter. So maybe I think this was what is given in the question. Okay. Yes, everybody, come on, friends, don't be just spectators. Okay, try to attempt these questions. Why? Because there is every possibility, even if you are not if you have not written this INICET exam, still if your aim is FMGE or NEET, every possibility is there that these topics will be repeated. Okay, so it is we can say a very important repeat. So there is a prick with vegetative matter, or they can also mention rose, a gardener is there who is taking care of rose plantations, and there was a thorn prick. That can be a question. Or they can even give you a farmer who walks barefoot, gets a thorn prick or some prick, after which there is development of this kind of a linear lesion. So what is the diagnosis, or what is the organism? Please remember, very important. The answer is Sporotrichosis, and in fact this topic, mycetoma, chromoblastomycosis and sporotrichosis, which all of them which fall under the basket of subcutaneous mycosis or implantational mycosis or inoculation mycosis, are very important. And in all of them, one thing will be common: trauma. That can be anything: thorn prick or vegetative matter prick, or barefoot walking on the soil. So these three conditions you must read and go. Don't go without reading. These are most likely going to be asked as image based question. As you can see here in the picture, what you are able to see, there are some erythematous papules and nodules arranged in a linear fashion. This is what is mentioned in the question. So I'm not sure whether this was the image which was actually given in the exam, or whether this was the image, but one thing is sure, both of them are showing that there is a linear pattern of the arrangement. And why is this linear pattern seen? Is why? Because this Sporotrichosis, when it gets inoculated into the skin, it will invade the lymphatics. Very important for you to remember. It will invade the lymphatics, and slowly it will move from more distal parts of the body to more proximal parts of the body. So there can be history of thorn prick, as I've told you, and this condition, sporotrichosis, is also called as rose gardener's disease. Very important clues. And like this, so it will invade the lymphatics, and it will go more and more proximal, and not only just the skin involvement, but this can also involve lungs also. That is, pulmonary sporotrichosis can also happen. And this linear fashion of involvement, due to the lymphatic spread, it is given a specific term called as sporotrichoid pattern. sporotrichoid pattern, and this sporotrichoid pattern can not only be seen in sporotrichosis, but also this is seen associated with fish tank granuloma, which is also called as swimming pool granuloma. So just tell me what is the organism which is responsible for this condition, fish tank granuloma or swimming pool granuloma? Yes, very good. I hope everyone will answer this. Yes, Dr. Tubarias, definitely we are going to see few more questions are there. But tell me the answer for my question, fish tank granuloma or swimming pool granuloma is caused by which organism? Yes, Mycobacterium is okay, but what is the species name? I want that also. Okay, I can see that there is difficulty in typing the answer. Very good. I think you are trying to tell Mycobacterium marinum. Yes, very good. You are absolutely correct. So even this condition, not only that, even lupus vulgaris and leishmaniasis can also show this sporotrichoid pattern of skin lesions. Sporotrichoid pattern. Okay, very, very important. And if you do a biopsy in the case of sporotrichosis, we can see asteroid bodies. So what are these? Central yeast will be there, which will be surrounded by a eosinophilic material. So this is the asteroid body where you are able to say central yeast, which is surrounded by this eosinophilic material. Eosinophilic material, and this is the yeast. This is called as asteroid body. And in the treatment, this is a fungal infection. So if the cutaneous lesions are there, we can use itraconazole, which is the oral antifungal. And if there is a lymphatic involvement in the form of linear nodule formation, then we can use saturated solution of potassium iodide. But if there is involvement of lungs, then we should use intravenous amphotericin B. So amphotericin B, I hope you are all very much well versed. During the COVID time, this was very important medication which was in the news. And yes, this was the question. I hope all of you might have answered this correct. That is the reason why I asked what were the other options, but students were unable to remember what are the other options. So most likely, I think all of you might have answered this correct. So whenever you see a patient coming with vesicular lesions as seen here, that is fluid fill lesions, which are situated in a single dermatome over chest, which are associated with pain. So these are the important clues: vesicular lesions in a single dermatomal fashion associated with pain. The only diagnosis which you must think is herpes zoster. So let us quickly see what is this, what the hell is this herpes zoster. So basically the human herpes virus 3, which is called as varicella zoster virus, which is a DNA virus. This is going to present clinically in two forms. So in the initial infection, then it will produce what is called as chicken pox, that is varicella. And once it will be seen usually in the childhood. So in the childhood, there will be infection with varicella zoster virus, and the virus will manifest itself. So all this again, if we go, it will be very detailed description. So chicken pox, I hope all of you know. Dewdrop on rose petal appearance, pleomorphic type of lesions, centripetal distribution will be there, centrifugal spread will be there. And once the infection gets settled, what will happen? The virus, it lies dormant in the dorsal root ganglion, and when it gets reactivated, it is going to manifest. Usually this will be seen in adults. This will be manifesting in the form of what is called as herpes zoster. Herpes zoster, which is also called as shingles. It is also called as shingles. And now the manifestation clinically will be different. Now there will be unilateral involvement, and that too it will involve only a dermatome. That is, what is a dermatome? It is a skin. It is a portion of the skin which is supplied by a particular nerve trunk. Okay, that is called as a dermatome. And the most important dermatome which is affected in herpes zoster is thoracic dermatome. And yes, these are the features of herpes zoster, which is also called as shingles. So unilateral dermatomal involvement in the form of multiple grouped vesicles. So this term is important. The vesicles should be in a grouped fashion. As you can see, they are all grouped here. And these vesicles are present over erythematous base. And most importantly, if the patient may not have these skin manifestation, but still the patient will have one important symptom, and that one important symptom is pain. So pain is going to be the most important symptom which the patient will complain of. And these painful grouped vesicles, when they heal, they might leave behind scarring, pigmentation, but some patients unfortunately will have the persistence of the pain, and this is called as post-herpetic neuralgia. Post-herpetic neuralgia. And when we are going to call this as a post-herpetic neuralgia, when the patient is going to have persistence of the pain even after 30 days, that is 1 month of the healing of these lesions. Okay. And yes, so I was told that this question was given. So elderly man, so I didn't got the question. So elderly man uh, came with the complaints of this kind of pigmentation, which is looking like a somewhat gray colored pigmentation is there. And in the question it was mentioned that he was on pharmacy, polypharmacy. So you are given options, which of the following drug can produce this kind of a pigmentation. So can anyone tell me what is the answer for this question even without the options? This is very important question, and I hope you might have answered this correct. Yes, can anyone try to tell? Yes, tubarias, sumagenic, Dr. Akash. Yes, everybody just give me a thumbs up if you are all with me watching this session. Yes. What do you think is the answer for this question? So if you have read this, you can say, was amiodarone in the options? Yes, very good. Amiodarone is the answer, and a long-term usage of amiodarone in certain individuals can produce what is called as photosensitivity. The patients can become very much sensitive whenever they are exposed to the sun or light, and also they are going to develop this gray, slate gray pigmentation, mainly involving the face. So elderly having a history of polypharmacy, having gray, slate gray pigmentation over the face, only drug which you must think about is amiodarone. Very important. Okay, so this slide again can be asked, so please make a note of this. Very important. Yes, I was told that this question and this picture were given. So a man from Bihar with childhood history of prolonged fever, with now coming with nodular lesions on the face, and there was no hypoesthesia and nerve thickening. So picture is given where you are able to see some nodules are there, and there is also hypopigmentation which is visible. Yes. So what is the diagnosis which you have marked? What is the diagnosis which you have thought? Yes, everybody please attempt in the chat section. This question, PKDL is the answer. PKDL stands for post Kala Azar dermal leishmaniasis. Dermal leishmaniasis. Okay. So I was told that these were the other images, that is over the neck there was hypopigmentation, and it was mentioned that there were infiltrated nodular lesions on the face. Okay, so these were the clues, and you must just know one of the concept. Very good, Dr. Akhila Reddy Ramedi. Yes, post Kalaza dermal leishmaniasis. So just remember that the Leishmania donovani, this is going to produce Kala Azar, which is also called as visceral leishmaniasis, which will manifest as fever and hepatosplenomegaly. And this condition is very rampant, common in Bihar. So this word Bihar is also given in the question, is what students have told me who written this INICET exam. And so what happens is, if this condition is not treated properly when the patient gets Leishmania donovani, then what happens, it can manifest in the form of post-Kalaza dermal leishmaniasis later on. So this history, that is a prolonged history of fever, which was given in this question. So prolonged history of fever in the childhood is trying to give you a clue that previously the child in the childhood age, the patient got Kala Azar. Okay, and it was not treated properly, most likely. That is the reason why it is now manifesting in the form of post-Kala-Azar dermal leishmaniasis, where the patients are going to have hypopigmented macules on the trunk, on the back, on the neck, anywhere over the body. And not only that, there will be infiltrated papules, plaques present over the face. So you can see there are infiltrated papules present over the face. And one very important differential diagnosis for post-Kala-Azar dermal leishmaniasis is lepromatous leprosy. So LL stands for lepromatous leprosy. And how can you differentiate? Very simple. So in the case of lepromatous leprosy, there need not be any history of fever in the past. So the history of fever will not be mentioned in the question. And most importantly, positive findings which can be seen in leprosy are there will be nerve thickening, and also there will be impairment of the sensations. And also in the slit skin smear, we can see acid fast bacilli if it is lepromatous leprosy. Okay, whereas in the case of PKDL on GIMSA stain, we can see Leishmania donovan bodies, which are basically amastigote forms of Leishmania donovan. This question was also important. This amastigote form is the LD bodies. Okay, and culture medium which is used is Nicole Novi McNeil medium. Okay, this is also important. Okay, and why are these two important differentials? Why? Because both of them can present with hypopigmented macules over the body, and both of them can have nodular lesions over the body, and the endemic areas for both these conditions is also the same. So all these features make it very difficult for us to differentiate both of them. That is the reason why in the question examiner will give you some other clues, like for example history of a fever will point out towards diagnosis of PKDL. Okay, don't worry, examiner will not be like a villain. They will give some very good clues in the question. And this was also discussed by me previously in one of the videos. So 35-year-old male from Bihar comes with complaints of hypopigmented macules on trunk and face. The nerves and sensations are tested to be normal. So nerves and sensations are normal. No scaling is visible in the lesions. The patient gives history of prolonged fever 2 years back, for which he was treated. So now tell me, what is the drug of choice for this condition? Yes, please try to put your answer. This is not, a recall question of INICET, but I am asking you, this could be a potential future question of both FMGE as well as NEET. So try to answer what is the drug of choice now. That is, I am asking about PKDL. We can greenish discharge with strawberry cervix. What is the drug of choice which you want to give? Yes, Dr. Akash says it is metronidazole. Yes, everybody agrees with metronidazole, or you're having some difference of opinion. And also one more question I want to ask. So if you have to give a kit, a NACO kit to this patient, what is the NACO kit which you want to give? What is the kit number? What is kit number? What is the kit color? What is the kit color? And what will be the drug which will act against this organism which is producing this greenish discharge? I hope you might have understood that it is Trichomonas which you are talking about, Trichomonas vaginalis, which is producing this greenish discharge, and also strawberry cervix. So please try to answer my question. So what is the kit number, what is the kit color, and what is the drug inside this kit which will act against Trichomonas? Yes, come on. Very important sexually transmitted diseases topic. You must answer this. Come on friends, anyone, what is the kit number? So I hope all of you know this very important trick. Kit 1 is urethral discharge. Kit 1 is urethral discharge. Okay, please remember this, urethral discharge. Kit 2 is vaginal discharge. Kit 2 is vaginal discharge. So rest of the other kits we will look at. So as the days go, I am planning, as I have already told you, I am planning to make live quiz sessions. Do join this, subscribe to this YouTube channel, so that you are going to get all the videos authentic with answers, correct answers, without any iota, without even an iota of doubt, you can mark these in the final exam. Okay. I've always forget these. Okay, please cover this short here, sir. So it will become a little bit lengthy, Dr. Akash. That is the reason why I don't want to cover this. So no problem. Do not worry. Before the exam, definitely. Every day I'm planning to make a live session. So please do join, and you are going to get definitely just spare 10 to 15 minutes every day. You are going to get all the important concepts covered in my YouTube channel related to dermatology. Okay, Rubarias, it is kit 2, very good. So very good, it is kit 2. I will give you the answer, don't worry. So it is kit 2, which will be green color. And in the kit, the drug which acts against trichomonas, it is secnidazole. Secnidazole. But here it is metronidazole, which is the drug of choice. Okay. So a few points about trichomonas. Of course, trichomonas vaginalis is the etiological agent, and please remember these three conditions are going to be discussed in vaginal discharge. But out of all these three, very important for you to remember is trichomoniasis is the only condition which is having a sexually transmitted disease, sexual STD. It is the only one which is a sexually transmitted disease. Others are not considered, not regarded as STDs. And in the discharge, in the trichomonas, please remember green frothy discharge is very important descriptive term which you must remember. And can anyone tell me in candidiasis what is the discharge? What is the description of the discharge? Yes, anybody? Simple one word is there for this. So I will tell you the answer. It is curdy white discharge. It is curdy white discharge. Okay. And in the symptoms, please remember trichomonas is going to have both foul smelling as well as itching as the symptom. Very important. Whereas if you look at bacterial vaginosis, very classically itching will be absent in these patients. And you know the reason why? Because in bacterial vaginosis, actually this is not an infection. That is the reason why it is not called as vaginitis, but it is called as vaginosis. So because it is not actually considered, I think I'm in the way. So 1 second, I will vanish. Okay, so here you can see itching will be absent, and not only that, if you look per speculum, there will not be any inflammation. No inflammation will be there in bacterial vaginosis. Okay. And one more thing, in this you must remember that in candidiasis, this is the only condition which is responsible for vaginal discharge, which will have a vaginal pH which is acidic, that is less than 4.5, whereas both the others are going to have more than 4.5, that is alkaline pH. And per speculum trichomonas, I hope all of you know strawberry cervix will be there. And if you do a potassium hydroxide in candidiasis, we can see pseudo hyphae. And in the case of trichomoniasis, we can notice with the help of potassium hydroxide, whiff test can be performed, and not only trichomonas but also in bacterial vaginosis also whiff test can be positive. And in the wet mount we can observe WBCs in this condition, and the organism trichomonas can be noted here. And because there is no inflammation in bacterial vaginosis, in wet mount we are not going to see any WBCs. No WBCs will be seen here. Okay, so these are some of the features. And if you look at the okay, so this is 1 second. So this is the green frothy discharge. Frothy is bubbles, air bubbles are there, so it is called as frothy. So green frothy discharge you are able to see. And mind you, this is colposcopic pictures which are mentioned here. And this is the cervix. Okay, 1 second, let me go up. So in the cervix you are able to see RAR. So in the cervix you are able to see there is multiple small erythematous lesions are there. These are basically due to the inflammation of the cervix, which you are able to see here. This is in fact called as colpitis macularis. So there are some erythematous macular lesions. over the cervix on colposcopy, and this is the reason why this is also given a descriptive term called as strawberry cervix. And all these features, when you are able to see, it is a diagnosis of trichomoniasis. Okay, I hope everybody has understood this. Everybody please give me a thumbs up if you have understood this. And diagnostic microscopic feature of LCH. So yes, everybody, those who are watching, please do give this video a thumbs up if you are able to understand whatever has been discussed. Yes, diagnostic microscopic feature of LCH. LCH stands for Langerhans histiocytosis. Dr. Akash says option A is the answer. So please also give this video also a like if you enjoyed this session till now. Yes, A is one answer which I got, and yes, rest of the other students, what have you marked? So I hope everyone has marked A as the answer. And if you marked A as the answer, very good, you have marked it right. So, and please tell me what were the other options, if you can remember. Please tell me what were the other options. So Langerhans cell histiocytosis is basically due to proliferation of the malignant proliferation of the Langerhans cells. So Langerhans cells, they are present in the stratum spinosum. They are present in the stratum spinosum, and basically these cells are the antigen presenting cells which are derived from the bone marrow, that is mesoderm, bone marrow or mesoderm. And if you observe these Langerhans cell, if there is a proliferation and if you observe them under electron microscope, so few students told me that sir, electron microscope was not mentioned, but still maybe the examiner just wants to give it roughly that you should think about that it is electron microscope only. So in the electron microscope we can see tennis racket shaped structures which will be present inside this Langerhans cell. These are called as Birbeck granules, and basically why are they tennis racket shaped? Because one end is oval and the other end there is a rod-like structure. So that is the reason why these Birbeck granules are described as tennis racket shaped structures. And finally, anaphylaxis scenario is given. So students told me that a bee sting happened in a 9-year-old girl, after which the child developed anaphylaxis like features. So what is the immunoglobulin which is mediated? So yes, hobby B. So AIIMS is the hi-fi, so you should think about electron microscopy only maybe. So yes, please try to answer what is the correct answer which you have thought about in this question. So anaphylaxis is basically type 1 hypersensitivity reaction, and I hope all of you know that this is a pathology question, not actually a dermatology question. Yes, Vikram Vishnoi, Dr. Sai Subramaniam, you are right, it is IgE mediated. And this was question oil red O stain you will use on a specimen with. So these were the options which students told me. Yes, what do you think is the answer for this question? Is it frozen section? Is it formaldehyde? Is it glyceraldehyde, or is it alcohol? Yes, friends, everybody please try to put your answer oil red O stain. It is basically, is it glyceraldehyde? So why so much of crying? Yes, what is the answer which others thought about in this particular question? So I am not sure, but as far as I believe, it is frozen section. So have you marked option C as the answer, Dr. Akash? So that's why initially I told you that don't feel bad. So don't take life seriously, and I'm telling life, you should not take life only seriously. Then what is the purpose of taking the exam so much seriously? It's okay, you made a mistake. So all those students who made a mistake, remember, learn from your mistakes. So maybe this is not the day for you, this is not the exam for you to crack. Maybe you are having even something better in the store. That's the reason why maybe you missed out this. So please learn from your mistakes, don't repeat the mistakes, and also do the questions which you made wrong as corrects in the upcoming exams. That is NEET. Okay, that should be your target. uh, so that's it, what I want to tell. Don't take anything so much seriously, and always you should feel that I can do it, and you should take a pledge that you are going to do the best. And I hope that those students who felt that this session was very easy or average, I wish that you are going to get a great rank in this session, and you are going to take seat through this INICET itself. And if you are new to this, their group links are there. My dermatology Instagram, Telegram groups are there. The links will be there in the description. You can click them and you can join with the help of them. And these were some of the other questions which I am not sure about. And if you could help me out regarding these questions, please do tell me what was the question, what were the images. Was this image actually given in this question? Were these options actually given? Was this the actual question? Please do tell me here in the chat section, friends. Uh, so these are some of the topics for all the other students who have not written this exam. You can just watch this and see what the students who wrote this exam have to tell about these questions. And also, otherwise, if you want to leave this session, please do give a like to this video. And before giving a like, do not leave this video. And also do subscribe, so that if you want any help from dermatology, you can get it from a certified dermatologist without any iota of doubt. Okay, so that is myself, Dr. Maddineni Srinivas. And yes, please, you must answer my question. What is this actual question? So these kind of questions basically are, we can say, most likely to be again repeated in the next sessions of INICET, or maybe they will be also taken in the upcoming FMGE or NEET also. So please help out, guys. What is this actual question which was asked? Yes, anybody, come on, put your answer in the comment section, friends. What was the actual question which was asked? Yes, friends, itching with vaginal discharge. Was this just the question which was asked? How can you diagnose this? I don't know. Itching and vaginal discharge. Option A, Gardnerella. So any other clue was given? Was this the image? Yes, just this. Tubarius says yes, just this is given. And was there, this picture, exact picture, was this the exact picture which was given? Not able to recall. Picture was different. No clues, no clue cell was there, or no comma clue cell was there. There is a some difference between both of them. Can Dr. Priyanka please tell whether clue cell was given? If clue cell was given, then the answer is very simple. It is bacterial vaginosis, and yes, you can answer it as Gardnerella. One more option is Dorderline bacilli. So Dorderline bacilli is nothing but lactobacilli. And if it is bacterial vaginosis, lactobacillus will be reduced in numbers, and that is the reason why the pH of vagina is becoming more alkaline. Okay, no clue cell was there. If no clue cell was there, then And one more thing, actually, itching which is given in the question, it is against the Gardnerella. Why? Because in bacterial vaginosis, itching will be absent. Okay, but if clue cell is given, definitely we should think about bacterial vaginosis and we should mark as Gardnerella. But definitely if clue cell was not there in the question, then because itching is there, then we should think about the diagnosis. It could be something else. Any other clue was given in the question. Why? Because trichomonas and candida, both of them can be the answer. And I can't find what is this image which is actually there, and image was different, so question is completed. One request to all of you friends. So if if you have seen the image which was given in the exam, please post that image in the Telegram group. The link for Telegram group is there in the description. Just click on that group and join the my Telegram group. The name of the group is Crack Derma DrMSD, and post your image in that group. Okay. And one more question on Hansen. So this is also